words in French and afterwards in English. Et c'est un énorme plaisir d'avoir ce grand monsieur avec nous, parce qu'il a fait énormément pour la profession et pour le plaque kinésiologie en général. Il a fait des découvertes incroyables, il continue de travailler tous les jours, d'apprendre tous les jours. Il a appris avec le père fondateur de le plaque kinésiologie. Et qui ne connaît pas le plaque kinésiologie? Tout le monde connaît AK? Tout le monde, qui connaît AK? Levez la main. Ok, so everybody knows AK.
Okay, good, okay.
So, c'est juste à part dire que c'est une grande légende et que je le remercie énormément d'être venu au Conf Chiro. J'espère que pour les étudiants qui n'ont pas pu le voir en séminaire cette fois, vous irez le voir si la ICK arrive à faire revenir. La ICK, c'est l'association française des quais qui organise de nombreux séminaires pour qu'on puisse apprendre le plaque kinésiologie sous toutes ses formes, sous les formes chimiques, sous les formes émotionnelles, sur les formes structurelles, même sur la grossesse. Donc je vous encourage à vous approcher de l'association. Je regrette que Florent Fournier, qui est le président du chapter, n'ait pas pu être là parce que je l'ai prévenu un peu trop tard, il n'a pas pu changer son billet. Et surtout un énorme applaudissement pour monsieur.
I am going to speak in English, and if I speak too fast, somebody raise your hand and say "lentement" or something. Okay. I'm impressed by how you speak French and you understand English, and I speak English and understand this much French. But we have one common thing if you do applied kinesiology. We all speak one language the same, and that's body language. The body language is muscle testing. And I learned that from Dr. Georges Goodheart, the founder of applied kinesiology. When I was a child, my family moved next door, the house next door to Dr. Goodhart's house. And from the age of 10 years old until now, my family lived next door to the Goodheart family. So when I was growing up, Dr. Goodheart was my next door neighbor, and our families played together. We had games in the backyard together. We went skiing together, snow skiing together. Dr. Goodheart loved to ski, I loved to ski. We did many things together as we were growing up. So he had a big influence on my life. You might say he had a very large influence, a huge influence on my life. So when I was growing up next to Dr. Goodheart, if anyone in my family had anything wrong with them, they would go see Dr. Goodheart. And we all learned about applied kinesiology by being his patients. My brother, who's 7 years younger than I am, is also a chiropractor and does applied kinesiology. So there are two of us, and my siblings, my brother, I have a brother, a sister, and a brother who passed away a couple of years ago. Of four of us, we were all patients of Dr. Goodheart. Two became chiropractors, and two of us do applied kinesiology. Dr. Goodheart treated 5 generations of my family. Think about it. He treated my grandparents, my parents, my siblings and me, my brothers and sisters and me. He treated my sister's children and my brother's children, and my sister's grandchildren. 5 generations. That's amazing. I don't think I'll treat 5 generations of any family, but it was just a truly amazing thing. So we were all very impressed by Dr. Goodheart and what he could do for our families. So I became a chiropractor really because of what I saw him doing for me and for my family. And when I was in college, I went to Duke University in North Carolina, where I met my wife, who's sitting in the back of the room, and we went to Duke University. And at Duke University, I was an athlete. I was on the swimming team. So I was on the swimming team for 4 years. And then I played other sports, and I played ball, really. And I was a pitcher in softball. And so in baseball, people always want to know, how did you actually get interested in chiropractic? Well, I got interested in chiropractic and applied kinesiology because of what Dr. Goodheart did for me and my family. But there was one particular time in my decision of what to do with my life. And I was my senior year in college, and I was pitching in softball, just like that. And the batter hit the ball right back at me, and I went to field it, and it hit a stone and bounced not in my glove, but into my left testicle. That hurt. It hurt so bad I ended up having to stop the game. I went to the hospital, and I was in the hospital for a week with that injury. My left testicle got very large. As the years go by and I tell the story, it seems to get larger. But it was very large and very painful. And they were talking about doing surgery if it didn't get better. That was right at the end of my senior year in college, my last year in college. And so I went home, I graduated from college, and saw Dr. Goodheart. And the first thing I did when I got home was have him treat me. He found a category 2 sacroiliac subluxation. From the force of that testicle hitting, the ball hitting my testicle, it also hit my pubic bone and knocked my sacroiliac out. He found a gluteus medius weakness, which is related to the testicle. And he found that neurolymphatic reflexes. Do you know neurolymphatic reflexes? Neurolymphatic reflexes, the points you rub. He found the neurolymphatic reflexes for the testicle. Extraordinarily painful. And he rubbed those, and it hurt almost as bad as the testicle hurt. It went down half in size. Treated again. The sacroiliac was okay, but he had to treat the reflexes more to make the gluteus medius strong again. I mean, you can see with the gluteus medius weak and from the testicle, and then the sacroiliac was out, why that subluxation didn't fix itself. But it held overnight when he treated the gluteus medius, but he had to treat it again. That second night, my testicle got smaller by half again. He said, come back tomorrow. I went back the next day. I said, I don't want you to treat me today. He said, why not? I said, because if it gets half again smaller, it will be smaller than when it started. But that's a story that I was so impressed by him, and that was the story that made me realize that I really did want to get into chiropractic and applied kinesiology. So he helped my parents, my grandparents, and my siblings at that time, and he was so helpful for everyone in my family. I wanted to do what he did, but that was the story that kind of made me realize I need to be able to do this for people. Because the surgeons were just going to do surgery and drain it. You don't want that when you're 22 years old, you know, anytime really. But so that's how I actually got into chiropractic, was living next door to Dr. Goodheart, seeing how he helped my family, and also that particular story that in chiropractic college at the National College of Chiropractic, I graduated and went and practiced with Dr. Goodheart for 5 years. One of the things that happened is he would always be coming up with new techniques. He had a research tape that he put out, an audio. It was a tape. In the old days it was tape. It was like the audio recording. Now every month he had an audio recording of the new techniques that he developed. It was amazing how much information he was producing. And he would have doctors come to his seminars, and then doctors would send him patients from all over the United States. And he couldn't see all those patients. So I practiced with Dr. Goodheart for 5 years when I got out of chiropractic college, the first 5 years. And during that time, Dr. Goodheart had one of his original study group leaders, one of his original applied kinesiology teachers, who was in New York, who had a patient who he couldn't figure out what was wrong with her. And she'd been having dizzy spells, just all of a sudden get real dizzy, lightheaded, feel like she was going to fall over. All the tests that were done were negative. This man, this doctor in New York who was treating this patient, the patient was his chiropractic assistant. So he knew her very well, and Dr. Goodheart knew her also because she was at the seminars. She would come to the seminars with the doctor. And so he said, he said to Dr. Goodheart, I would like you to treat my assistant. And he said, I can't do that because I don't have time. He was traveling and teaching every weekend. He said, but let Wally see her and have her come for 3 days in a row. Wally will treat her. The first day, Wally will examine her and treat her. The second day, I'll come in and I will look at her and we'll decide if there's anything else that needs to be done, and then Wally can do it. Well, this doctor who referred this patient was an excellent doctor at adrenal glands. He'd written papers for ICAK on adrenal glands. And so if people are dizzy or lightheaded, when they stand up especially, that's oftentimes stress related and related to the adrenal glands, And the blood pressure, if your adrenal glands are weak and you stand up fast, the blood tends to flow down into the abdomen, away from the brain, and you get dizzy. So the first thing you would think in a patient who is having this transient dizzy spells would be the adrenals. But her adrenals were fine. There was nothing wrong with her adrenals. I treated her. I found maybe one subluxation and just very small things wrong with her because she'd been treated so well by the doctor that she worked for. So the second day, Dr. Goodheart came in, and he met her, and he said, "Hello, how are you?" And she said, "Well, I'm doing okay, but I have these dizzy spells about once or twice a week, and I haven't had one in a few days, but they keep coming back." And he said, "I want you to do a test for me." He said, "I want you to do the finger to nose test. You know the test, finger to nose. I want you to do that test." He said, "Do the finger to nose test like that and like that." And she did that. We all know that test. He said, "Now, turn your head to the right and do the finger to nose test." She went like that. He said, "Turn your head to the left and do the finger to nose test." And she went like that, like that. I never saw anybody do a test like that before. But he took a basic standard neurological test and he modified it, and she stuck her finger in her ear. Amazing. So he looked at me and he said, "Wally, she will have an occipital subluxation. The direction of correction will be very precise. And you'll have to use the vertebral challenge." You know vertebral challenge technique? The vertebral challenge? You push the vertebra through its range of motion and test the muscle. He says you'll have to do the vertebral challenge technique to identify the exact vector or line of correction. And after you adjust it, she'll be fine. And so I challenged her occiput. It needed to go like that, some funny direction. It wasn't just straight any way. It was kind of up and in. I adjusted it. It went boom, like that. Big, loud noise. Afterwards, she was like this. All three positions were fine. She never had another dizzy spell. So it was, even though she'd been seeing a good doctor and had all kinds of tests, it wasn't there because someone hadn't done the right test on her. So Dr. Goodheart had this kind of innovative mind, like no other doctor I ever met had. He would figure things out on patients. And he taught me how to figure things out on patients that were maybe things that weren't in the textbooks, maybe things that you wouldn't normally study in school, but it would be based on physiology, based on anatomy, based on neurology, based on the basic sciences. But each patient is a unique patient. And we always like to talk about research studies and seeing large numbers of people and having evidence-based treatment and so on. But the next patient that comes into your office might not be in this part of the bell-shaped curve. They might be out on the end of the curve. They might be the 5 or 10% of the patients who don't act like all the other patients. So we have to have a tool to identify what's unique about each patient. And we start with the evidence-based activity. We start with physiology. We start with neurology, anatomy, biochemistry. And then what we do is see if it works on that patient by using muscle testing. And muscle testing is that body language that we can use to tell what's going on with each patient that's unique about that patient's care. And so just like he did the test on the standard neurological test, but he changed it, then we had to use muscle testing to identify the exact line of correction, which made a huge difference in that patient's health. So we start with the evidence-based activity, but then we need a tool to identify what if our patient doesn't fall in the mid-range of the average patient. And that's what muscle testing is, and that's what applied kinesiology is. So we now say that if you have a study of 30 patients, then we say N is 30. And for research, N is 30. If you have 100 patients, N is 100. N is the number of subjects. Well, each patient is an N of 1. Each patient is their own research project in a way, because they are going to respond differently in some way than any other patient you have. So that's where muscle testing and understanding body language, understanding the responses the patients have, plays such a large role in helping patients, especially the patients that no one else helps. So I want to tell you about a couple patients that I had just recently. I'm a consultant at a place in Philadelphia, Pennsylvania, in the United States, where they treat brain injured children. And they have institutes in 6 or 7 different countries where they have brain injured children come from all over the country or all over the part of the world, and they have their program they put children on by identifying exactly what each child has wrong with it, unique to all the other children. So they have, each child gets a different program based on how they assess the nervous system development of that patient. So I consult with them every year for the last 20 years. My friend Jerry Morantz, who lives in Chicago, Illinois, and I go there every year for a day and a half and consult with them and teach them things about AK. Now, you cannot do muscle testing on a brain injured child, right? You can't do muscle testing on a brain injured child. This last week, we were there 2 weeks ago today, and we had 2 children that we treated to demonstrate. One was 2 years old. You can't do muscle testing on a 2-year-old child anyway. But it was a brain injured child. And you can't do muscle testing on a brain injured child if they're 10 years old. So we had 2 children we demonstrated on. Now, you can't do muscle testing, but what we could do is we could do range of motion testing. We were measuring rigidity of the patients. Rigidity. The patients, like they were like this. The one girl was like this, and you could barely push her arms down, and then they'd come back up. And they had different types of rigidity where they couldn't get their leg out to the side, couldn't stretch the legs apart, and so on. So what we had to do is we had to think in terms of what muscles would be weak if the patient had this rigidity. We had to think like backwards. We had to think, normally we think what muscle's weak, and a weak muscle causes a tight muscle, and we test the weak muscle. In this case, we had to look at the tight muscles and guess what muscles would be weak, and then treat the patient. And when we treated those patients, we found in 15 or 20 minutes dramatic changes by applying neurology and applied kinesiology techniques, the techniques from applied kinesiology, but without muscle testing, but with testing rigidity patterns and seeing what we could do. And in 20 minutes, 15 to 20 minutes, we could get the child's arms to change like this, their legs to go out to the side like that. And the director of the institute came up to me afterwards and he said, "You have done in 20 minutes what it takes us 3 months to do with our rehabilitation program. In 20 minutes, using applied kinesiology techniques. Not muscle testing, but using applied kinesiology techniques." So the reason I'm telling you this is I want you to appreciate the strength and the power of the tools that we have in chiropractic, and especially in applied kinesiology, to change things that no one else can change. No one else does that. But we can do it. We all have different interests. We all have different interests in what we want to treat. Some people want to treat pain. Some people want to treat stress. Some people want to treat autoimmune disease, multiple sclerosis, and Crohn's disease, and those types of things. Well, thank you. I forgot I needed that. Thank you. So all people have different interests. When I first got in practice, I wanted to treat athletes. I've been an athlete, I wanted to treat athletes. And I did treat some athletes. I treated some professional athletes and some college athletes. But the most people that came to my office were women with female problems, with hormonal problems. I had the biggest number of my patients were women with hormonal problems. So I learned a lot about treating hormones. Even though I thought I was going to be a sports doctor, I turned out being a doctor who treated endocrine problems. So sometimes the path you go on is different than the path you think you're going to go on. And I wrote a book in 1981 about endocrine problems. So it took me a different path. So you're not quite, no one's ever sure where they're going to end up going, but I want to tell you that the world of disease is open to what we do with applied kinesiology. We can help anybody with anything. We can't necessarily cure everyone with anything, but we can help anyone with anything. Think about it. A patient has autoimmune disease. Before they had that autoimmune disease, do you think they had some muscle imbalances before the disease manifested? Yeah. Patient has heart disease, cardiovascular disease. Do you think before they had cardiovascular disease that they had muscle imbalances? Yeah, they did. Patient has even cancer. You think that before the cancer showed up, they had muscle imbalances? Yeah, they did. And some of those patients would be our patients who came in with a shoulder problem, maybe because of a subscapularis weakness, but it was the beginning of a heart problem. Or maybe they had a shoulder problem because they had an infraspinatus weakness, and we know the infraspinatus is related to the thymus gland and immune system. And maybe the shoulder problem was because they were starting to have an immune system problem. And maybe they had a latissimus dorsi weakness, and maybe the latissimus dorsi weakness affecting that shoulder was because of a pancreas problem. So we have to know that the muscles that we treat and the musculoskeletal issues we treat are oftentimes coming from some other problem in the body. Dr. Goodheart and I were talking about a patient when I was in practice with him. And the patient had a pancreas problem. And the patient was hard to diagnose. And Dr. Goodheart referred the patient to a medical doctor that we knew, that referred patients to get more diagnosis. But Dr. Goodheart was talking to me, and he said, the patient's going to have either this, it was a pancreatic problem, he's going to have this, he could have a diabetic problem, he could have a beta cell benign tumor, he could have a pancreatic beta cell malignant tumor. He listed 6 or 7 things that could be wrong with this patient. And I said, Dr. Goodheart, this was when I was in practice for like 1 year. He said, Dr. Goodheart, you have to know, to be in practice, you have to know as much as all those people in the other professions know. And he said, no, Wally, that's not true. You have to know more than they know. You have to know what they know, but then you also have to know what you know. You don't have to know every diagnostic test, and you don't have to know every treatment procedure that other professions do, but you have in other professions for diagnosing and treating so that you can add what you do to that. So with that opportunity, between using body language and muscle testing to identify what's wrong with patients, many times years before that problem manifests itself as a named or known illness. So all the time when we're treating patients, we need to be thinking, is this something else going on with this patient? Is there some other problem that's manifesting by a musculoskeletal imbalance and a muscle weakness? And that's what our training is for in school. That's why we study physiology. That's why we study neurology. That's why we study biochemistry. We study those things. But when we're treating patients, we can think, what's going on with this patient? What does this muscle test mean? Does it mean anything, or is it just a muscle weakness? So many times it means something else. And we can start with our patients and prevent illness in patients of all different types. And then when they get these difficult problems, we can also treat them using natural therapies and support whatever else other doctors are doing for the patient. So with that concept, I had a patient. Her name was Goldie. She was called Goldie. And when I first saw her, she was about 50 years old, maybe 50 years old. And she had had rheumatoid arthritis her whole life from when she was in her teenage years. She had rheumatoid arthritis, and it was so severe that when she was a fairly young woman, she had no movement in her hip joints whatsoever, no movement at all. She couldn't move, she couldn't walk, she couldn't even lie down flat in bed because her hip joints were so frozen. So they did surgery, and they removed both hip joints. Now that meant she didn't have any more hip joint pain, but now she was in bed or a wheelchair for the rest of her life. So she was confined to her bed. They used to bring her in on a hospital bed into my office, and I would treat her on the hospital bed. She was contorted like this, literally, like this, with rheumatoid arthritis. And she had a stick, like a back scratcher. It had a stick that she would use to do different things, touch herself or scratch or whatever, because she couldn't move any more than this with her arms. So she used a stick to reach different places. And she needed to have her blood drawn. She needed to have her blood drawn at least once a year for her lab tests, and no one at the hospital could draw her blood. I don't know if you do draw blood in France? Do chiropractors do blood tests? Okay. Well, we were trained to draw blood, and I could always draw her blood. I could always hit her vein when the people in the hospital couldn't. So once a year she'd come in and I'd draw her blood and I'd treat her. So one day, her house caught on fire. She lived in the second floor. She was in the second floor of her house, and the house she lived in caught on fire, but she can't move because she's in bed. She has no hips. So her family could not get up to the second floor to reach her. So they called the fire department. The firemen went up the ladder, went into the window, and carried her out the window and saved her life. But she had very serious smoke inhalation. She was in the hospital. Now she had rheumatoid arthritis, and all of her joints were fixated, and even her ribs barely moved. She had very low vital capacity. So she had all this smoke she breathed in, and she couldn't cough it up. And it was congesting in her chest and her lungs, and even said, would you come to the hospital and treat her? Because the doctors say that she's not going to last more than a few days because she'll catch pneumonia and die. Or maybe her lungs will just fill up with fluid because of all the smoke inhalation, and she'll die. They were suctioning her throat and her lungs out. The family was, when she started coughing, they'd stick a tube down her throat and suction the mucus out. And that was the only thing that kept her alive, because otherwise she would have drowned in her own fluids. When I saw her, there's very little muscle testing I could do, but I did test her deltoids. Now, she had very limited motion, but I could test her deltoids, which relates to the lungs. The deltoid muscle relates to the lungs, and they were both very weak. So I rubbed the neurolymphatic reflexes, which I call them Chapman's reflexes. I mean, Chapman developed them. I rubbed her Chapman's reflexes for about a minute, and all of a sudden, she coughed all the stuff out of her lungs. 3 days later, instead of being dead, which they had predicted, she was home out of the hospital and doing fine. Very Chapman's reflexes for the weak muscles, which related to the lungs, saved the woman's life. There's no question about it. And no one else knew to do that. I didn't know what I know, and I had to know what they know also, because she had this congestion problem. I had to be able to work with those doctors. So that's the first thing that happened to that woman that was dramatic. She went on to get back to where she'd been before, and then about 8 or 10 years later, she developed lymphoma. And so she called me on the phone, and she asked me if there's anything she could do for the lymphoma. That she knew she was going to die. She knew she was going to die from lymphoma. She had a terminal diagnosis. But she said, eat, because there's a big lymphoma mass in my abdomen. And when I eat, lymphoma mass pushes on it, and I can only eat a little bit of food at a time, 2 or 3 bites, and then I can't eat anymore. And she was starving to death because she couldn't get enough calories. She was dying from lymphoma, but she really felt bad because she couldn't eat food, and she couldn't get enough calories in to have any energy. Her blood sugar would be low, all the things we know from someone who's on a starvation problem. So I saw her one time only during that period. And I found out a very simple technique. It's a technique that we call set point. And Michael Leibowitz, who lives in Washington State right now, he's lived in different places. My friend Michael Leibowitz is an AK chiropractor, and he and I developed this technique which uses the acupuncture head point techniques. In AK, they call those the B and E techniques. B for beginning and E for end. Dr. Goodheart called the 6 acupuncture points on the head the B's of the acupuncture meridians. And there are actually 6 meridians on each side, and then 2 midline meridians, conception vessel and governing vessel. And Michael Leibowitz and I developed this technique where you find a problem in a patient, have them touch the problem, say it's their elbow, touch the problem on the head that relates to that part of the body. So all the acupuncture meridians run through different parts of the body, and we developed this technique which is basically touch and tap. So you touch at the knee problem, touch the knee, and tap the acupuncture point on the head that relates to the meridian that goes through the knee. Might be gallbladder 1, might be stomach, but that's the technique. It's called set point technique. It's one of the main pain control techniques that we use for people who had injuries. When I saw her in my office, she could touch the mass in her abdomen. I mean, she could barely move, but she touched the mass in her governing vessel 27, which is a midline point. And when I did that, she felt some relief in her abdomen. So I had her do that every day before she ate, touch and tap. During the time she ate, touch and tap, and then she could eat tapping, set point technique, until she couldn't eat anymore, or she got full, she had no more need for food. And so what happened, she started getting more nutrition, and she stopped starving to death, and she felt much better. She was still dying, and she still died of lymphoma, but she was free of the discomfort from the pain of eating, and she was free of the weakness and the lack of energy from not having enough calories in her system. And it was a huge thing for her. When she died, a few weeks after she died, her daughter came into my office. And she said, "I have a message for you from my mother. She told me to come and talk to you when she died and tell you, thank you." She said, "Tell him, thank him for treating me like I was living while everyone else was treating me like I was dying." Everyone else had given up on me. Everyone else just wrote her off. She's going to die. That's all there is to it. But I treated her to get as much out of her life as we could get out of her life, even while she was dying, which had a huge impact on her last several months of her life. She basically died with no pain, and she died with no fatigue from the lack of calories. She didn't starve to death. She died from lymphoma relatively comfortably. Thank you for treating me like I'm living while everyone else is treating me like I'm dying. I think that was the best compliment I ever got from anyone. We can do things for patients with our hands that no one else can do with the most sophisticated equipment in the world. Dr. Goodheart used to say, we treat people with our hands and our heads and our hearts. But we treat people with our hands to start with. And that's what we can do. That's the tools we have in applied kinesiology. That's the tools we have in chiropractic, where we can do things that no one else does, no matter how high of skill they have, no matter how much technology. We can't always save people's lives, but we can make their lives better. And that's what I wanted to talk to you about today, is the scope of what we can do with our hands and our hearts and our heads. The scope of people we can treat. We all have different interests. We might be guided, like I was, away from sports and into treating endocrine problems, and now the neurological problems and autoimmune problems and all types of things that I never thought I was going to do when I first was in practice. And we all have our own interests. And we'll all go in different directions. But what we need to remember is the power of what we have. and our hands, our heads, and our hearts to be able to help people get more out of their life, even when they're dying, but especially when they're living, to get a better quality of life and to better reach their optimum human potential. Well, thank you very much for having me. If you have any questions, I'm happy to answer any questions. Anybody have any questions? I have a question. Where's a good place to eat? My friend says there's not a bad meal in France. No place to eat bad in France. So, anything else?
Profitez-en, on va pas l'avoir souvent.
Yes.
Could you speak about the quintessential applications?
Oh, thank you very much. Thank you. Yes, let me tell you about that. First of all, I'm teaching a seminar this weekend. I'll get to that in a minute. So when I was first in applied kinesiology, I started practicing in 1975 in Dr. Goodhart's office. For 5 years I practiced in Dr. Goodhart's office, and in 1980 I started my own practice. There was so much information coming from Dr. Goodheart. One research recording a month, one book a year. And then we had the International College of Applied Kinesiology started in 1975, and the people who became diplomates in applied kinesiology were required to write at least one paper a year in those days. And so we had book 2 meetings a year of ICAK. One book had this many papers, and the second book had this many papers. So every year there was this many papers coming out on applied kinesiology. So much information from so many sources. And it was overwhelming. No one knew where to start. Dr. Goodheart would always say, I'd say, why did you do that to that patient? He said, in 1953, I saw a patient who had a similar thing, and I remembered that. Well, I was in practice for a couple of years, and he had 30, 40 years of experience. How do you do that without that experience? So in 1978, I started looking at all the information that was coming out and trying to put it together, figuring out the most optimal way of what to do first, next, and last. What was the best order to do something? And so if there were 3 procedures, I would do them like 1, 2, 3 on one patient. The next patient, I'd do them on 3, 1, 2, different order. The next patient, I'd do 2, 1, 3. I'd mix the order up, and I'd see which ones worked better in the office. And then when the patients came back, which one had the best outcome after they left the office. I did that for 35 years. I still do it today, to figure out what's the best thing to do first, next, and finally last on a patient. And that's what Quintessential Applications is. Quintessential Applications is an optimal order of how to do things first, next, and last. It's based on basic sciences, biochemistry, neurology, and basic principles of physiology. And after watching what to do first, next, and last for all these years and applying basic sciences, I came up with a protocol, which we call the Quintessential Applications Clinical Protocol. So my friend Carrie McCord was helping me teach the basic 100-hour AK course. The basic AK course has always been a problem of the student gets so many techniques but doesn't know what to do first, next, and last. So what we did was we started with the basic AK course and put it in the order of what to do first, next, and last. We expanded it to 15 sessions instead of just 8 sessions. We had to add material that wasn't in the basic course. And we put it together in a way that is how you can start with the patient and see what to do first, next, and last. Although every patient is different, you can start with every patient the same and go through the order the same, and it all makes sense. For example, for example. We know that stress suppresses the immune system. So if you have a patient with an adrenal problem, and their adrenal glands are fatigued, and you treat their adrenal glands and increase their cortisol, but their immune system is stressed and is fatigued also, during the time that the patient's stress was going up, their immune system was going down, and then their adrenals went down. That's what happens. Then you treat the adrenals. As you increase the adrenal function, guess what? It pushes the immune system farther down, even worse. So the way to treat patients before you treat the adrenals, or at the same time you treat the adrenals, you must treat the immune system. And then when you treat the adrenals to push the immune system down, when you increase the cortisol and increase the adrenal function, it won't push the immune system down to a dangerous level. It's things like that. It's hundreds and hundreds of physiological principles of what to do first, next, and last. Now, every patient is different. A patient might walk in with an emotional stress problem, and you might have to treat the emotional stress problem because someone in their family died or got sick or something. So that might be the first thing you want to treat on a patient, but that's okay. You might do it on that patient that day, but then you follow back into what to do first, next, and last. It's like a roadmap. The Quintessential Applications Protocol is like a roadmap. Gets you from here to here. You can take side trips, but you always have a path to come back to get you back on center. And that's what QA is, basically. So it's many, many techniques, all physiologically based, basic sciences based, and what to do first, next, and last. So we have this course, which we have professionally video recorded. The course is online, and the doctor, whose name is Shannon Weeks, is an AK doctor. He's the guy who's doing our marketing for the course online, and he has a special free offer for people at the seminar this weekend, which he told me I could offer to you. And if you go to this website, I'll write it down. It's QA Home Study .com /Paris. That's supposed to be Paris. QA Home Study, QAHomestudy.com /Paris. Is that right? Yes. And if you go to that website, you will see a free video on injury recall technique. It's a technique that is maybe I consider the most important technique that I use in my office. And it's a pain relief technique, and there's a brief video on that. And then there's another brief video, about 15 minutes or 20 minutes, on how to diagnose visceral disorders using visceral referred pain areas. You know referred pain areas? Patient gets a heart attack, they get pain in their arm. Patient gets kidney stone, they have pain on their side. Well, it's how to use the referred pain areas with muscle testing to make diagnosis. These are just some introductory videos, but you can go there and you can download them. Now, it's a promotion. So what they'll do is if you do that, they'll get your email, and they'll start sending you emails about the things we're doing, which is fine. If you don't want them, you can unsubscribe, but I would recommend you can go look a little bit to get a little bit idea of some of the things we do. And then once a month, if you're on our email list, we do there's about a 30-minute video on some part of some technique that we teach. It's on a Tuesday. It's called Technique Tuesdays. There's things that are offered and things from the website. So you might want to do that if you're interested. And that's one way to find it. I meant to tell you that, and if you didn't ask, I would have forgotten. Anybody else have any other questions? Is it hot in here? Is it hot? It seems hot to me. Anybody else have any questions? Yes.
Would you do novel screening muscle testing, meaning taking 12 muscles in relation with each organ to know where to start from?
Would you take one muscle from each organ to know where to start from? I don't do that. Some people do that. I start with postural analysis. Then I measure what's wrong with the person. If they have shoulder pain, I measure their shoulder pain. If they have back pain, I have them bend. And then I'll watch them. So I see their posture, and then I see their movement. And from posture and movement analysis, I will see where I think there are muscle imbalances and muscle weaknesses. So high shoulder, I think there's a lat, maybe, you know, all the postural things. I'll watch somebody walk. If they're walking like this, I'll think there's a latissimus dorsi, that type of thing. If they raise their arm on one side, and their arm on this side goes up, and their arm on this side goes forward, it might be latissimus dorsi not pulling it back, just for example. So I do those things. And then I do the temporosphenoidal line, the TS line, which is a shortcut, but some people don't like to do that, but I do that to find the weak muscles. And then what I've learned to do is start with a weak muscle or two weak muscles, and then look at the patient neurologically based on the QA protocol. It's all neurologically based and chemically based. But I'll figure out what, if you follow the QA protocol, it would tell you what neurological things to fix first, next, and last for each of those weak muscles that you have. And so instead of identifying one meridian for one muscle for each meridian, sometimes 2 or 3 muscles might get better from one neurological technique. So it's not, there's nothing wrong with doing that, looking at each meridian, but that's how I do it. I find that many times, if you look at a muscle imbalance, sometimes all the muscles that are weak are extensors. Latissimus dorsi, gluteus maximus, there's a latissimus dorsi, and patterns are easily corrected if you look at the protocol that I developed over 30 years. It fixes it automatically. And then we do the acupuncture, acupressure for pain relief, touching and tapping like I mentioned. We do that, and then we have other acupressure things we look at the end. Okay. Yeah. But it's okay to do it that way. Any other questions or thoughts?
What kind of samples do you use to test chemical treatment?
What kind of samples?
Yes.
I use the actual chemical if I can. So we test, for example, ammonia. Have patients sniff ammonia. We test bleach, which is hypochlorite, OCl, hypochlorite. Sniff bleach. We actually test the chemicals like that. We test nutrients by having them taste the nutrients, of course.
Okay.
But there are some chemicals which are in homeopathic little vials. And so that's the only way you can find them. You don't have enough to sniff or taste. So we test with homeopathic vials using a magnet, which is, I'd rather do the oral testing or the olfactory testing, but you can do the magnet testing if you have a homeopathic and there's only this much. If you use only this much and you use it on 2 patients, it's gone. So that's what we do. Okay? Okay. Any other questions?
We thank you just to say we treat person with help them express better life. So what chiropractic is about. Thank you very much for coming to offer some time and sharing with everybody who's present. Some guys on videotape.
Thank you. Thank you all for being here. Thank you for coming.